good evening, everyone. I'm Dr. Nivedita, and I welcome you all on behalf of Team Netflix. So, this evening we have with us Dr. Chirag Shah, who is an MD Medical Oncology and Hematology from the USA. He is currently a consultant hemato-oncologist with Apollo Hospitals, Ahmedabad, with nearly 2 decades of experience. Also, his areas of interest lie in stem cell bone marrow transplant, hemato oncology, breast cancer, head, neck, gastrointestinal, liver, lung, and other cancers as well. Along with that, Sir has a number of publications to his name. Really lucky to have you with us tonight on Netflix, Sir. And we'll get started with your discussion.
Namaste, and thank you, Nivedita, for that introduction and Netflix. Today's topic is chronic myeloid leukemia, a very important topic because CML is one of the poster child of the targeted therapy, the first real targeted therapy in the field of oncology, hematology came in CML and changed the survival, the prognosis completely. So let's see. Uh, Today we'll talk about CML main aspects. That is, one, it is one of the best curative cancers or one of the best survivals in CML. How to make an early diagnosis, how to monitor the treatment for response, and the role of tyrosine kinase inhibitors, the targeted therapies, and functional cure. We will be using the CML tree that you are seeing here, which at multiple times to understand the how the diagnosis is made, the pathophysiology, the monitoring, and treatment. So first of all, the molecular genetics of CML. We are all aware of this, that this was identified about 3 decades ago, that BCR and ABL join to make a BCR-ABL protein, and these are derived from chromosome 9 and 22, and this BCR-ABL protein turns on the cell proliferation continuously. So that leads to accumulation of more and more cells, and that is how we see the CML patients with high white cell count and many times with high platelet count as well. Now, why CML is important? Why we are discussing this topic? For this one slide, if you can remember, that is the most important message of today's talk, that CML, now treated well, has survival same as general population for those who achieve complete cytogenetic response within 2 years of starting imatinib. So this is very important, that a cancer which, when I was in medical college about 25 years ago, 30 years ago, the median survival was about 2-3 years. And many of you may remember these were the patients in the exams, practical exam with large spleen. So for the splenomegaly examination, uh, these were young patients, and unfortunately they survived very short. And now we are talking that their survival is same as general population. This is something we can say for very few cancers today, that having survival same as general population. Okay? So we'll talk about these other the parameters that define that success over the talk. Now, as you can see that imatinib, um, how it changed the survival. If you see the lowest graph, the lower two graphs are with hydroxyurea and busulfan, and that uh, the survival was very low. And then with interferon alpha, the next graph, it improved a little bit. Then with stem cell transplant, it reached somewhere in the middle here. Okay. And now with imatinib alone, it is here. So this is the power of the tyrosine kinase inhibitor imatinib, where the results are so much better than even transplant. Okay? We got from transplant, which is the kind of ultimate curative treatment in blood cancer, what it could achieve and what imatinib is achieving is so much better. So that is why early diagnosis of this disease is very important, because we can give a great prognosis survival to these people. So how do these people uh, present? These are some of the examples from our practice. 40 years old man with fatigue, weight loss of about 5 kg over 3 months, and on examination you find a spleen about 4 centimeter below the costal margin. And you do a workup, basic workup. CBC shows WBC of 70,000, hemoglobin normal, and platelet also 800,000, 8 lakh, high platelet. A very classic presentation. Then there are other people who present slightly differently, like this woman who came to us with only a high platelet count at 18 lakhs, but with normal WBC and hemoglobin 12. She had a workup somewhere else with bone marrow, blood workup, molecular test, that is JAK2, and she was labeled as myeloproliferative disorder, essential thrombocytosis. And she was started with hydroxyurea, but she was not getting very good control of platelet. So she came to us, we did the workup, and she was diagnosed to have CML, and that led to her appropriate treatment with TKI, and within 1 month her platelet count was normal and is maintained like that now for about 2 years. And this is an increasingly common scenario. A young woman or a man going for pre-employment health checkup or routine blood workup, find a slightly raised WBC with smear normal, everything else normal. Patient is asymptomatic, so they are called for a repeat CBC after 1 month by the physician. Again, no change. They are asked to follow up after 6 months. WBC is slightly higher, now 18,000, but the smear review is again normal, and patient is completely asymptomatic, working 10 hours a day. So nobody is understanding what is going on. They are referred to us, and we do the test, and the diagnosis is made. So the typical presentations of CML are that now increasingly asymptomatic high WBC count, whether it is done for routine health checkup, pre-employment, or sometimes for some other thing, like the patient going for a surgery, hernia surgery or a cosmetic surgery, anything else, and they end up getting blood test which shows high white cell count, and they get diagnosed. The typical presentation we all know is fatigue, weight loss, low-grade fever, early satiety because of a big spleen, abdominal discomfort, and on examination, classical splenomegaly. Uh, a very odd uh, presentation in some patients is reduced hearing. So people who get WBC over 5 lakh, 7 lakh have reduced hearing, and as their counts are improving with treatment, their hearing improves. This is very unusual finding. Atypical presentations is increase in platelet count only, and if the platelet count is more than 10, 15 lakh, these patients may come with bleeding, such as we had a patient with 30 lakh 32 lakh rather platelet count who came on a Sunday with significant bleeding from gums. So in this patient, we had to do emergency lowering of platelet count by platelet apheresis to control the bleeding. And by reducing the platelet, you improve bleeding. And these are the patients whom you should not be giving aspirin for high platelet count. So actually, this is acquired von Willebrand disorder. We will not go in the detail, but important to remember that patients with extreme high white cell platelet count don't start aspirin. Another uncommon, very uncommon presentation is only high eosinophil count. So eosinophilia more than 5,000, 10,000 can occasionally be a presenting feature of CML. The typical blood smear in CML is called as bone marrow in blood. So you see all the different cells that you are supposed to see in bone marrow are being seen in blood, such as normoblast, myelocytes, metamyelocyte, promyelocyte, etc. And however, again, remember that those occasional patients who present with minimal white cell count as part of routine checkup frequently have a normal blood smear. So if normal blood smear but persistent WBC over 6 months, you have to think of CML. Now, uh, what is the diagnostic test? Based on the smear and history, we have suspected, but the diagnostic test is to find BCR able. So this is the confirmatory test, that protein which forms from the translocation of 9 and 22 chromosome pieces. And what are the tests? So initially we were doing bone marrow, and based on morphology, people said that okay, this most likely is CML. But the diagnostic test is to find BCR able translocation by karyotyping, which was the oldest test, but it has the sensitivity of finding about 1 in 50 cells, 1 in 50 abnormal cells. Then came fish analysis, which is more sensitive. So occasional cases which were missed by karyotyping are picked up by fish. And PCR is a technique that detects between 1 lakh to 10 lakh, uh, one cell between 1 lakh to 10 lakh uh, in the bone marrow. So most sensitive test. We use it more for monitoring rather than just the diagnosis, although it is very good for diagnosis as well. And what this tree is showing you, that the what you are seeing above the surface is the white cell count, and what you are seeing below the surface is the root cause of CML, and the root cause is this genetic change. And as you go lower and lower, the PCR is the smallest roots, and our goal is ultimately to eliminate the smallest roots so that we get the best disease control. Now, etiology of CML, patients always ask, but no one knows. Various theories, but the only known established cause is high atomic radiation exposure, as in Hiroshima or Nagasaki. Uh, but in the routine life that we see today, there is no identifiable cause. What is the prognosis? Again, survival is same as general population for those who achieve complete cytogenetic remission within 2 years of starting imatinib. So important to remember that this is a disease we would like to diagnose early, and we need your help in early diagnosis and timely treatment so that we can give these people the best survival. So now we will talk about the medicines, but very important from the point of view of non-hematologist oncologist is the fact that these are the factors affecting prognosis and where you can make a difference. So the number one factor is compliance, number two is compliance, and number three is compliance. Okay. So the idea is that I'm highlighting the importance of taking very, very regular medicine. The studies are shown that if you miss even 3 to 4 tablets a month, your PCR control rate goes down, means your long-term survival is compromised. And this is where your role is very important to continuously emphasize to the patient that they should not miss any tablet, even if they have minor side effects such as acidity, bloating, little bit of edema. There is a tendency to stop the drug, worry about the long term side effects, short term side effects. Somebody will come and say, oh, allopathy medicines are not good for this, that. If there is edema, very common side effect is a little bit of orbital edema. Um, and so in the morning, when they see this edema, or when the friends and family tell them, oh, you have something, you have edema, you look different, people tend to get worried. A lot of people associate edema under the eyes with kidney damage. So they think that there is something happening with their kidney and they would stop and check. Please don't do that. And uh, I emphasize this at many visits, initially much more times, and later on also, especially when the reports are good. Because when the reports are good, there is a tendency to again be complacent, and it is okay. Now we have anyway achieved excellent remission. So even if we forget, sometimes it is okay. That kind of tendency settles in the patient's mind. So please, you must advise your patients, because after the initial care, we call these patients every 3 to 4 months only. So that is only 3 times a year. That means they are following up with you more times. So they should not stop medicines out of fear with drug interactions without checking if there is a really need to stop temporarily, if they are getting any antibiotics or any other intercurrent illness, or um, they may have gastritis and they may stop. So whatever different reasons, they may think that it is okay to stop. If they have a fever, viral fever, they'll stop for 5 days all medicines. So please, at those points, make sure that they don't stop this medicine. And by far, with large majority of the drugs, it is safe to continue TKI, especially if it is a self-limiting illness where you are going to give medicines only for about, say, 5 days or 7 days. Then there is not even a need to worry about drug interactions. Other factors are various scoring systems. All these scoring systems take into account mostly age, spleen size at diagnosis, platelet count at diagnosis, and blast percent in peripheral blood. Very surprising and interesting fact is that the white cell count is not in any of these prognostic scoring systems, which is uh, one of the interesting aspects of medicine, that when you analyze large database, you sometimes find things which seem so simple, logical, that white cell must be a part of the scoring system, but it is not. And there are a few other things like cytogenetic abnormalities other than Philadelphia chromosome or bone marrow fibrosis at diagnosis. So now coming to the treatment, um, what are the treatment options? The older ones, hydroxyurea or busulfan, which, as we have seen, they work only uh, very poorly, and if you remember the initial survival curves, they are providing very low results. Then the interferon. Um, when I was in fellowship, we were using interferon. At that time, even pegylated interferon was not available, so this was a very difficult treatment. Every day injections, very few people could continue. Even with peg interferon, a very long term is not easy. Um, and the results are, of course, not as good as TKI. And then in 2001, uh, during my third year of fellowship, this data came out and it changed the landscape completely. And the before imatinib across the world, the number one transplant indication was chronic myeloid leukemia. Number one across the world in all the major transplant centers. After imatinib, now it is not even in top five. So that's the power of imatinib, that it has replaced allogeneic transplant as the first treatment or even second treatment. So TKI is the tyrosine kinase inhibitors, is what we will be talking. Uh, the how do we monitor, before we go on? How do we monitor these people with blood counts, bone marrow cytogenetics, and PCR? Again, the improvement in the PCR technique has allowed us to stop doing bone marrow cytogenetics repeatedly because the PCR correlates so well with the prognosis. And um, this is the point. If you remember, the complete cytogenetic response here, which correlates with a PCR of less than 1%. And if you remember, if we can achieve even this complete cytogenetic response, as we've seen earlier slides, makes the survival as normal as general population. Whereas our drugs today go far below that. So um, this uh, picture here is showing how we are able to now achieve PCR less than 1%, then less than 0.1%, and deeper molecular remissions we can achieve up to less than 0.003%, which is known as the MR 4.5, molecular remission 4.5. That is the current best achievable measurable outcome. So reminding again that if you achieve complete cytogenetic remission, this survival is same as general population. And uh, this we have already discussed, that complete cytogenetic remission correlates with a PCR of less than 1%. So now, what is our treatment goal? Now, over these 20 years, a lot of work has happened in the field of CML, understanding the monitoring also, how best to uh, follow these people, minimize the need for bone marrows and other workup, and make their life very easy. Uh, so current uh, goal is to achieve at least MMR, which is PCR less than 0.1%. So PCR less than 1 is what we saw is a very good result already, but we are aiming a little higher for the safer side, that PCR less than 0.1%. Now, we were very happy with this level of response, which is known as MMR. And when patients achieve this, we told them there is nothing more to achieve and just continue the drug and kind of be happy. However, at that point, we were telling the patient that you have to take this lifelong. And then came this data of TFR, or potential cure, which we will talk about. And there, the achieving the PCR even further below these smaller roots of the CML tree became more important, because now if we are able to remove the smallest roots of CML tree, then we can even stop the drug in some patients. So that is where we started measuring PCR more frequently. The TKI is available now. 2001, it was only imatinib. After about 6 7 years, we had dasatinib and nilotinib. Then very recently came bosutinib, ponatinib, and last 1 year or so even asciminib. So now we have 6 different TKIs. What was the need to have all these TKIs? Because we know that yes, imatinib is wonderful, very safe in most cases, and uh, you know, great results, survival. But in the original study of IRIS study, the 2001 publication, we saw that about over the years, about 40% of people, for various reasons, ended up needing to discontinue imatinib, either because of progression or some kind of intolerance. And because of that, there was a need for the second generation TKIs, which are nilotinib, dasatinib, and bosutinib, and then third generation TKIs, which is ponatinib and asciminib. And they overcome the resistance to imatinib in many cases. We have now the ability to measure specific mutations. So based on mutations, we can decide that if somebody has progressed on imatinib and has, say, X mutation, then we go to this drug. Y mutation, we go to this drug. Z, we go to other drug, like that. So that kind of detailing is now possible, which allows the survival uh, to get even better and better. So now, coming back to the CML tree, why did hydroxyurea and busulfan did not improve survival? Because even though these drugs improve the WBC count to completely normal, these two drugs can make your CBC absolutely normal, and yet you don't get any improvement in survival, because you are not doing anything to the root cause, and the root is where these newer drugs work. So imatinib was the first TKI which worked on this root, which we call the karyotype, the chromosomes, where it achieved 80% cases, it could achieve complete cytogenetic remission. And the optimal goal, which is MMR, it could achieve in about 60% people. And deep molecular remission, which is a prerequisite for potential cure or stopping the drug, in about 40%. Now, the second generation TKI here uh, did better on all those parameters, all the way up to deep molecular remission of 50 to 60%. So that is the power of the second generation TKIs. Now, so how do we choose out of so many drugs? Do we start everybody on imatinib, and then only if they have a problem we go to second generation TKI? No. These studies have clarified the role of these drugs as following: that if you have a high risk or intermediate risk patient by Sokal score, one of the scoring systems that we saw earlier, then you start directly with second generation TKI, because their survival is lower with imatinib, as we see in the next slide. If the patient has low risk Sokal score, then he or she has option of going to either the imatinib or the second generation TKI. Why? Because the survival as of now is same with both imatinib or second generation TKI in low risk, but the deep molecular response, the lowest roots clearance, is better with second generation TKI. So imagine the young patient that we saw, the 30-year-old girl, woman who at pre-employment health checkup had found CML. Now imagine telling her that you have to take this drug for lifelong, which means another 50, 70 years of her life. So for these patients, stopping drug has a huge value if they can achieve deep molecular response, and that is why, so if the patient is younger and places more importance on stopping the drug, then you start with second generation TKI. You don't wait for the first generation response. The what I mentioned earlier, that the survival at 10 years in the original study of imatinib in the low risk so-called score patient is almost 90%. In intermediate, it is about 80, and high risk, it is about 70. So 70, 80, 90. So for the low risk patients, clearly there is not much value unless you are thinking of stopping the drug. Now, so these studies then evolved the criteria as to when to start thinking about changing the drug if you have started somebody on imatinib. Uh, and this is like we follow the PCR at every 3 months initially until we achieve the optimum results. So as you can see here, that in the first, uh, the green one, the green here is optimum. So that means PCR should go below 10% at 3 months, below 1% at 6 months, and below 12 months at below 0.1% at 12 months. If this has not happened, then they are either in the warning area or in the red area depending on the level. So say for example, if at 12 months BCR is 0.1 to 1%, then you could still wait. This is a warning. So means you follow them more regularly, but you don't have to change the drug. And but if it is more than 1% at 12 months, then it is a failure. And that means you have to change the drug. So that is, we are not going in the detail of all time points, but this is an important understanding that how we are now able to predict well in advance as to which patient needs a change of drug. Now, it is important to understand that as of now, the second generation TKI at first line treatment from starting have not shown any improvement in head to head comparison against imatinib, showing any improvement in overall survival or PFS, progression free survival. So as of now, because of this reason, imatinib is still a reasonable drug to use. So if you have patient with multiple comorbidities, cost issues, you can still use imatinib only, and you don't have to go to second line TKI from start. However, as I say, it is more important for people who are thinking of PFR, the stopping the drug. So the benefits of second generation TKI as of today is mainly in the front line is to achieve a more rapid response and potentially develop fewer mutations because of quicker response, and slightly less incidence with nilotinib of progression to CML second or third phase, that is accelerated or blast crisis. Now, again showing this data of these various drugs giving the second line TKI, as you can see here, giving better, uh, the deeper molecular response That is, if you compare in the dasatinib trials, 33 versus 42%, in nilotinib again 30 versus 50%. So the deep molecular response is higher, as we had seen earlier in the CML tree also. Now, a brief comment on the adverse effects of these medicines. A lot of them are mentioned here, but the discontinuation rate due to adverse events of imatinib is extremely uncommon. Very occasional people develop severe rash, just like drug allergy that can happen with any drug. Very occasionally, lot of edema, and then we have to stop. And sometimes too much gastritis that people cannot handle, but that is rarely a cause for discontinuation. Similarly, um, with dasatinib and nilotinib, now the studies showing starting with a lower dose and getting the good control achieved even with lower dose has reduced the side effect rate, and uh, allowed to continue drug in most of the people safely, such as in dasatinib, lower dose of 50 milligram has shown excellent results, and at least in the study so far, the discontinuation rate is extremely low. The most common ones that I mentioned earlier, gastritis. So we advise them to take the drug after a meal, or at least after a big glass of water, preferably after breakfast or lunch. Avoid after dinner or late at night when the gastritis incidence will be higher. Um, the one of the side effects, which is, some people could say even a pleasant side effect, uh, also is that there is a kind of depigmentation, so people become fairer, and it is very noticeable within few weeks to months that the person becomes more fair, although some people become too white and they complain that the relatives are asking what has happened to you, you look very pale, and etc. Some people develop some pigmentation over the cheeks, which is a bit annoying to them, as when people are asking, and the baggy eyelids here, the edema. So these are the complaints of most people, because you know this is a lifelong treatment and people notice and ask about these things. Certain specific side effects to dasatinib is effusions, pleural or pericardial effusions, and pulmonary arterial hypertension. Some are short term, some are long term side effects. Nilotinib also somewhat increase cardiovascular events in the very long term, and in the short term, pancreatitis, high glucose, and indirect hyperbilirubinemia, QT prolongation. Ponatinib is fortunately used very uncommonly and is a difficult drug where the risk of thrombosis is high at the standard dose, but there are now studies of lower dose showing better safety and still good results. Bosutinib is more of GI side effect like diarrhea. So now last few points, the treatment free remission in CML. As we spoke about that, uh, the the biggest attraction now is that we are able to stop treatment. I have about 12 patients who have been now off treatment of CML for many years. One of them, a very young man, about 25, 28, when I think we started, and he was able to get off the drug after about 7 years, and that helped getting married for him, because you can imagine for a young person having a label of a lifelong disease and continuing treatment. So avoiding side effects that impair quality of life, especially in younger patients, is the number one reason uh, for stopping TKI. Some people have side effects which require stopping. Also, we don't know the very long term side effect of these drugs, although so far uh, it is fairly safe but not completely safe. And we understand that the data is only about 20-25 years old. So when we are talking about lifelong, means 50 years, 40 years, and even children have CML. So imagine a 12-year-old who starts taking TKI today and has to take lifelong. Right? So for them, this is very important. Another very important point is family planning and pregnancy. So for young people, that's a very big consideration. That if you are pregnant, you cannot take this drug, and that means it creates a big dilemma for them. One side they have to worry about the disease control, other side they are losing the age of getting pregnancy and they want to complete childbearing. So this is a very important discussion point in our practice with young patients: what to do, how long to wait, what are the options to use, etc. And uh, so family planning is one important. Financial reasons, we are talking about lifelong treatment, so the cost becomes important. Although I must mention now that luckily the cost of TKIs because of generic versions is very low now, and imatinib, good companies, imatinib is available at about 1500 rupees per month, uh, which used to be 200,000, 2 lakh rupees a month when the drug came out, and it came down to 20,000, 30,000, 10,000, and now it's less than 2,000 rupees a month. Now, although discontinuing TKI seems very exciting, but there are certain important criteria because we still don't know how many people in the long run will have a relapse of CML. Initially, when we stop, within those who are likely to relapse do so within generally first 1 or 2 years, and that too mostly 6 months. What has happened in my patients also, that for 6 months only they will have a PCR coming back from negative to positive. And but I had a patient who converted to positive after 7 years of being off treatment. So since we don't know which patients will actually be truly cured, we call this treatment-free remission or a functional cure rather than real cure. And that is why very regular monitoring is important. So when we choose a patient for discontinuation, we make sure that they understand the need for lifelong monitoring and repeated PCR. PCR is a bit costly test, so they have to understand that they have to do every 2 months this test for 1 or 2 years, and then at little lesser frequency every 3 months for uh, at least for lifelong as we know now, and over the years we'll know some more detail. Also, there are some criterias. I will not go in all the details, but briefly, the patient has to have he has to be on the drug for at least 5 to 7 years, and at least last 2 years, the patient has to be in deep molecular remission. That means the what we discuss less than 0.01 or less than 0.003. At least that level they have to be continuous 2 years. So the patient has to be very compliant also, follow up, and be able to get reliable repeated PCR. Uh, then only this discontinuation can be considered. And this is clearly so this is not a futuristic thing. Stopping drug is possible. As I've said, I myself have 12 patients at least, and there are more than 50 publications on drug discontinuation with more than 2000 patients in these studies who have been able to discontinue. So it is possible, and there again, your role is important, that if you are uh, following up with your patients about this and telling them to ensure that the compliance, then they will achieve these good results in the long term. And your nudge at every clinic visit to tell them that it is important, your small reminders will be very useful to them, and you provide them support and help, that if they are worried about the cost, then you can refer them to some NGO. You can let us know. If they are worried about side effect, you can let us know. Uh, if they're worried about child planning, again, we can counsel them. Uh, if they have gastritis, you can treat them. Uh, but those should not be the reasons to stop in between, let go drugs. Uh, so that when the all doctor community will understand the importance of compliance, we will be having these great results and will be able to even discontinue the drug in more number of patients. The this slide is showing that the studies done of discontinuation with imatinib, where it has been possible in about 30 to 60% patients. With the second generation TKI, we have achieved that in about 41 to 63, 67%. So almost same, slightly higher, you can say, with second generation TKI, and definitely faster with second generation TKI. So for younger patients, many times that faster is also important. They are in the age of getting married or in the age of getting children, and they want to get off the drug very quickly too. So in summary, my last slide, CML early diagnosis is very easy if it is suspected. So it is important to remember that CML is a possibility even in atypical presentations like very high platelet alone, very high eosinophils alone, or routine health checkup, no symptoms, mild high WBC but persistent. We don't want to start testing people or thinking about cancer in the first 1 or 2 months of high WBC. But if 6 months continuous, if there is high WBC, then this should be considered. Overall survival is now same as for general population in at least 80% of CML patients. Treatment is easy, oral once or twice a day, generally very well tolerated. It is not expensive, and there are many government schemes, NGOs, which provide these medicines. So no one should be left without TKI treatment in the first line at least. And close monitoring with PCR is important, not to get happy with just CBC coming normal, which also is an issue. Many people feel good, CBC completely normal all the time. They stop monitoring, coming to us, they don't get PCR check, and then they miss all the warning signs on the PCR and the routes from the we lose the control from smallest route to this level, this, and then they come here in blast crisis or full blown accelerated phase, and then the cure rates, especially after blast crisis, are very poor. Functional cure or treatment-free remission is now possible in about 50% of patients. And for those who fail first-line TKI, now several options are available with second-line TKI, and ultimately, hematopoietic stem cell transplant or BMT is still an option for some patients. And about 10% patients or so will still need the transplant. Thank you.
Thank you, sir, for that wonderful presentation. Y'all can start putting in your questions in the comment box, or you can also use the raise hand feature to come up on stage and have a discussion with sir. So we'll start taking a few questions that have already come in. We have Dr. Nisar Prasad who's asked, can child planning be done with a patient on TKI?
Excellent question. Yes, child planning can be done, but in the first trimester, the TKI has to be stopped. With second and third trimester, the knowledge is not very clear because it also depends on which TKI the patient is on. Then also, if the patient has achieved deep molecular remission, we can even stop the drug. And these things require a lot of discussion of the pros and cons, because on one side there is a concern of losing disease control, and the other side is child planning. But yes, in general, the child planning can be done while the patient is on TKI, and as soon as they miss the first period, then you stop the TKI. So in the first trimester, you are not on the drug.
Thank you, sir. So we have another question by Dr. Nisar himself. Can we shift to first gen from second gen when PCR goal is achieved? And when to change drug only for side effect from a side effect point of view?
Very good question. Um, Shifting from second back to first generation. No studies to show that. Uh, and if the PCR goal is achieved, then we assume that that goal is achieved by that second generation TKI. So you would ideally want to continue that to maintain that goal, because going to first generation, you might lose that goal. And when to change the drug only for side effect point of view, there are certain side effects which, if grade 3 or 4, for example, if somebody has a serious pleural effusions leading to major respiratory difficulty or pulmonary edema, we have had occasional patients. I remember at least two patients where I had to stop because of that in my 20 years of practice. So it happens, but those are very uncommon. Some people get very severe myelosuppression, their counts just stay low. We stop, hold, restart at lower dose, still they cannot. You keep on changing. Occasionally, rashes, of course, like any drug allergy. So, those are the points where we have to change.
I hope that answers your question, Dr. Nisar. Dr. Uday Sagar has asked, what happens if we diagnose incorrectly and give imatinib?
So the good thing is that incorrect diagnosis now of missing CML happens, but wrong diagnosis of CML is now very rare, because the testing is so good. Detection of BCR-able protein is now extremely accurate, and false positive is very rare. So, you know, and if this is not CML and if you give imatinib, you will also know in 1 or 2 months, because it will not work. So you will not get control of the white cell.
Yes, Dr. Ishfaq Gulzar has asked, the patient develops side effects on first gen TKIs, when to start second or third generation TKI?
Right. So, as I mentioned, some of the side effects, and then there are grades. So people would, if somebody develops mild pleural effusion, we would not change the drug. Or if somebody develops mild low CBC, mild to moderate, we will not change the drug. But if it is very severe, then we will change the drug. So every side effect, we grade them as kind of grade 1, 2, 3, and 4. So for a grade 4, we certainly change. Grade 3 plus minus, and grade 1 or 2 we generally manage with dose reductions.
Thank you, sir. We have Dr. Pooja Nagpal actually who has written a question, but Dr. Pooja, I'm sorry, I'm not able to read the question properly. If you don't mind, you can use the raise hand feature and come up on stage. I'm only able to understand, is this drug effective in, think, a broad, the comment has not come in properly. So if you don't mind, could you please retype that, or you can use the raise hand to come up on stage.
Yes, we
We
can see
have
now. Is this drug effective in BCR-ABL negative CML? Not effective. And now we don't use the word BCR-ABL negative CML. Earlier, this term was used, but not any longer. So those are not CML practically, and the drug does not work in those. Another question: how the effect is monitored? So, as we have discussed, the monitoring most commonly done with the PCR, although initially it is CBC. And in 90% plus patients, CBC will become normal within 1 month. We call it complete hematologic remission, that is achieved in just 1 month, regardless of the initial white cell count. Then, after 3 months, we do PCR and then we follow it every 3 months. Some people do a bone marrow with cytogenetics at 1 year, although we don't do it and most people don't, because for patients it is very inconvenient and a bit painful also.
so we have Dr. Krishna Priya who's asked if there are any risk factors for other family members uh, in CMI.
Okay. So the no known risk factors for practically all the blood cancers, CML, AML, ALL, uh, CLL, chronic lymphoid leukemia, none of these have known risk factors like we say about, say, breast cancer or head and neck cancers like that.
Mhm. Thank you, sir. Dr. Praveen Kumar has asked if the patient goes into accelerated or blast phase, will TKI still work?
So in the accelerated phase, the TKI will still work. Now, in that phase, we have to do the mutation check first,
Mhm.
because certain mutations will make the CML resistant to the standard drugs. So that means, um, like we discussed earlier, that if there is a X mutation, you give this drug, Y mutation, you give that drug. Say, for example, if T131I mutation, then only ponatinib or asciminib will work, nothing else will work. So none of the second generation TKI will work.
Mhm.
Uh, so there it becomes very important to do the mutation testing, which is again widely available in India now. Blast phase, the drug will work, but temporary. And in large majority of the cases, it will be few months and occasionally longer. So it's not 0, 0, but it is uh, nothing compared to what we're talking in the other phases. So that is why in blast phase, important to uh, refer the patient for transplant and seriously consider transplant and monitor their PCR very closely. Don't get happy with the CBC control. So if their PCR is not doing well, then you know that they have to go into transplant. Otherwise, if they are reluctant, if they are older, sicker, other reasons, then you may kind of continue monitoring with PCR. And there are patients who do well on TKI even after blast crisis, but it is a smaller number. So we have to balance in all the other factors.
So, uh, thank you so much, sir. I think we've covered all the questions that came in. Um, So if we'll just wait for a couple of seconds more, if there are any more questions, please put them into your comment box and we will answer them. So we have Dr. Purohit who's asked what to do if there is myelosuppression.
Right. So, depending on the grade, we would either continue, reduce the dose, or completely hold. Three levels. Now, in general, at least in the initial phase, we really want to avoid stopping the drug. This is a very important question. Thank you for asking that because this happens in the first few months very commonly. That people who would have a marrow clearance of the bad cells and then actually from say 70,000 WBC they will go down to 3,000 or 2,000. So people get worried, they stop the drug, hold it for a few days, these that allow it to come up, and that really reduces the long term control. And all the goals that we spoke about of achieving good PCR control at 3 months, 6 months, 1 year, all that, you lose out on that heavily. So for uh, say grade 2, 1, or even grade 3, we would actually push at that time in the first few months with growth factor support, etc. Because most of these will actually recover back to good level where we can continue the same. There are some people who even after the first month, 2 months, continue to have trouble. And they are the ones where we have to reduce the dose and occasionally we just cannot continue, unfortunately. We have to change the TKI, we have to do different things. But in general, we push through the myelosuppression without stopping the drug. Very important.
So, I think we are at the end of the Q&A. Thank you so much, sir, for coming on to Netflix, and we look forward to having you for more future sessions on Netflix as well. Um, we do have a session request. Please take a session to differentiate different blood cell disorders. So thank you, Dr. Nisar. We'll stay in touch with Sir and we'll plan these sessions with him as per his convenience. Thank you, sir. Wonderful session. And I'm sure our audience has taken a lot of knowledge back with them into their practice. Thank you so much.
Thank you, Netflix. Thank you, Dr. Nivedita, and all the listeners and those who asked all the questions.